is presenting. The patient is presenting. So those are issues that come in to support the provision of care within the risk that inherently available, that is certainly there. And then when you look at the individual clinicians or healthcare providers, we look at we talk about someone is speaking. Terry Kimita, kindly.
And they have chosen
Kimita.
Islam and Muslim.
Yes, and when you look at individual healthcare providers, there's cognitive biases and what we term as heuristics. And I think before, for example, personally, before I got inducted into the patient safety and quality improvement space, I never realized that I was biased. But the biases comes in, for example, when you see a patient, you've already made a perception around that. And those are the biases that we speak about. And in terms of heuristics, one, we are looking at how do we make decisions? For example, the gut feelings that we have, sometimes we're just too overconfident of a case. And that determines whether sometimes you also make an error, even though most of the cases, through expertise, we get it right. But that is, it is also error prone. And to manage also, one of the other ethical considerations in the practice of medicine is now accountability. As healthcare professionals, as healthcare organizations, being accountable to the services that we provide, either through peer regulations or through the policies that we've got or that govern the care of the practice that we are engaged in, and being aware and able to control what care you provide. And this is where we talk about overdiagnosis or overprescription, or you may be making a request or for an investigation that might not really be necessary, or you may be prescribing a device for use that may not really be necessary. And those are the elements that we could talk about in terms of accountability. And then within the entire ecosystem in the healthcare, we also look at how do we balance accountability in that whatever is system related is taken as system related, and whatever is individual related is handled at that and within that lens and brought into the perspective of improvement practice. And then there is the novice in the healthcare profession. Everyone at one time was a novice, everyone at one time was a student, and there's a time that you are green, there's a time you don't know how to approach it. But now, within the studies, the various studies also says that, okay, yes, the novice and the freshers, they make a number of mistakes as related to the experts in terms of error analysis. The experts make fewer mistakes simply because they've seen it more, and they've developed some sort of a disease slip or menu of sort in their minds, in their memories. So it makes it easy for them to practice. So in terms of ethics, do we then stop the novice from practicing? But now we can't stop them from practice, because it is through practice that they'll become expert. They'll become experts. So there are avenues to support the novices or people in training or the newbies in the healthcare profession. One, the practice is that you'll utilize more of simulation training, so that by the time as a clinician I transit to the patient, I'm fairly safer to provide care. And also, as a matter of ethics, whenever error occurs, because certainly errors will come and will occur, whenever something occurs, the patient also, because at that point there's the loss of trust between the patient and the healthcare professional or the caregiver of the healthcare organization. So one, we look at how do we provide that apology to the patient, because apology basically is a realization of human frailty, because the quality chasm spoke and said that human is to error. The error will always be there. So as a human being, or as a clinician, as a physician, as a diagnostician, you've got to be averse and be aware that error is there. And when something occurs, it's the apology in it is just to provide that perspective that yes, you are a human being and you are in error. And also, we also have to be alive to the system imperfections. Every system is always evolving and is always moving across and maturing within the space. So the imperfection is something that we have to be alive to. So an apology also just means that our systems are evolving, we are not perfect, and we are picking up these lessons to learn. So that is just a snapshot of how the various aspects of ethics in medicine and how it affects error. And with that, I give us another case study. DKS, a 45-year-old male street vendor, complains of sudden onset of a severe headache, states that he hasn't felt ill in the last 10 years, and this is the worst headache of his life. The nurse tells you he's seen him on the streets and known to smoke cannabis in the past, although she hasn't seen him lately. Patient examination is intact, except his clothing, which is a bit old and a bit shabby. Diagnosis of severe migraine made. You discharge the patient with oral medication. Accident and emergency admission at the casualty. 24 hours later, the patient is comatose. A radiology exam is done. CT scan shows a large subarachnoid hemorrhage. So just by the way of chat box, let's fill in. What do you think about it? Feedback. Peter will keep check on what is coming to the chat box before we move to the next.
Yeah, so you can post your reactions in the chat box. I can see, but I think Mohammed, this is related to the first case scenario of TB. It's okay. Yes. I think as you also post your responses, you could probably describe it a little bit further so that we get the real insight of the diagnostic error in such kind of cases. However, saying a lot of responses are talking about diagnostic error, misdiagnosis, bad prescription noted. Beverly Mohanja is the cause of all irrational drug use. Diagnostic errors being vital cause has everything to do with the kind of environment in which healthcare providers work in. So in today's era, everything has been monetized, sadly, including patient care. We work in systems in which sales are of vital concern rather than recovery of patients from hospital to clinics. Mwanja, thanks for that input. Quite long there, but very insightful. And this is what actually we call now the public health, discourse that you can actually have in the near future. Work in unfavorable environments, events, and such. Thanks. That is Mwanja, pharmaceutical specialist. Eric Kembo is asking about differential diagnosis. Yes, tell us based on this. Pamela Onyango is also saying the triage nurse had assumptions. And limited care, bias was noted. That is from Samsung. I don't know who Samsung here is. Hazel Oyongo is saying inadequate patient comprehensive examination. So meaning this client was not, the patient was not adequately examined. Alice Wamboi need to rule out other causes of headache by doing a scan since it is of sudden onset. A lot of assumptions from the patient's past, financial constraints from Oparanya. Oh, well, even the minister is here. No, this is Stephen Oparanya. Maybe it's the son. Thanks, we are blessed to have the minister here. Delayed diagnosis, missed diagnosis from Kirote. There's also Ruto here. Comprehensive history and examination was required. Poor first impression, wanting perception, lack of investigations, human factor bias, missed diagnosis. Yes, I think there are a lot of responses. A lot of responses are coming. So back to you, Otieno.
And it's quite good that the responses are touching on some of the things that we're speaking about. For example, when you talk about heuristics, these are the assumptions that we make in providing healthcare. For example, one, the nurse tells you that he's seen him on the streets and non-cannabis smoker in the past, although they've not seen him for a while. And then in your physical examination, is intact except his clothing and old, which is a bit shabby. For example, if this was this person, this 45-year-old was let me pick let me pick some neatly dressed insurance agent or a bank teller or a banker coming to you in a suit, and you make an examination and it's intact, you'd have thought of requesting for another examination, so something like that, or an investigation. So those are some of the biases, and the biases that comes in with us. You'll realize that even the way a patient is dressed is enough to give you a bias. You may not know it as a clinician, but it's there. Even the way the patient speaks and interacts with you is enough to give you a bias. That's what we talk about, the issues, the issues around cognitive biases and heuristics in the provision of healthcare. So what the nurse did, I've just placed the case scenario there as misdiagnosis, and what the nurse did, attributed this patient's presentation and complication to something else that might have been insignificant in this clinical case. For example, smoking bang or smoking cannabis previously. So that attribution error made the clinician or the diagnostician not to gather more information from the patient. So that is just a snapshot on how we relate issues around heuristics, cognitive biases, and how we support our patients. And then good, I also liked the information that comes. There was no differential diagnosis. So one way of debiasing healthcare diagnosticians, one, is to develop a differential diagnosis. Because one, if you make a primary diagnosis and you don't develop a differential diagnosis, you have nothing else to consider. And you have nothing else to rule out. You have nothing else to look into keenly or deeply. So one way as an action to prevent or to manage the cognitive biases that come, one, in relation to clinical reasoning, is one, to develop, to encourage diagnosticians and clinicians or physicians to be in the practice of generating or developing a differential diagnosis. I've seen, yes, some people have raised their hands. I think, Peter, you can manage that.
Yes, I've seen two people. Let me see. Skill Vincent.
Okay. So should I continue or we give here?
Vincent, you can unmute and you have something to say? Okay,
Okay.
Maybe it's a legacy hand. Maybe just proceed.
As we've had that preview, now we look at the diagnostic process and how do we place the patient at the heart of it. I'm looking at this with the lens of the patient and also with the lens of the team, the diagnostic team members.
Hello.
So every time you sit in your workstation or in your workspace, just understand that it's only the patient that will have that opportunity to walk through the entire ecosystem of your facility. You are not there, may not have that privilege, because the patient will walk the various as planned within the care management plan. So one, what happens? The patient will experience healthcare problems. And what we know nowadays is that before the patient comes to you, the patient has consulted maybe the brother, the mother, or the father, or the cousin, or a friend who is in the healthcare space. That's number one. Or the patient has also consulted Dr. Google. So by the time the patient is coming or stepping into your workspace, the patient has already ideas on what is happening to them. That is by the time now the patient is engaging the healthcare system. So when the patient steps into the healthcare system and engages the work system within every organization, one, the first part is that information gathering you're looking at now, the initial assessment, clinical history taking, interview, and the physical examination. You'll provide the diagnostician request for a diagnostic test and maybe a referral where necessary. And a diagnosis will be made and communicated to the patient. Sometimes it might not be communicated to the patient. And whatever is preferred is taken up as a working diagnosis is what will inform treatment. So you realize that before the patient is exposed to medication error, or before the patient is exposed to treatment error or a wrong treatment being provided, the patient would have been exposed to diagnostic error. So that is basically the floodgate. It opens the floodgate for all manner of errors that comes in. So as part of the working diagnosis, what refines the working diagnosis is what is observed during treatment. And this is where, for example, where that this is where now the team members come in. For example, within the diagnostic space, we've got team members who interact with the patient, they touch the patient, but they don't pronounce the diagnosis. For example, a patient is admitted. The nursing staff interacts with this patient. There is information the nursing staff is speaking from the patient. And this information is supposed to be plowed back into the information gathering, into the clinical review, so that we are able to better integrate this information into a proper diagnosis. For example, whether it is delayed, something missed initially. So this scenario provides us the team approach in that the diagnostic process is not a one-person affair. You've got the diagnostician sitting in at the center, maybe the clinician side by side, because minus the patient. Remember, this patient experienced this healthcare problem, and probably this patient has lived with this healthcare problem for a while now and is sort of an expert in their symptoms. They know how it feels. So having the patient part and parcel of the diagnostic team is crucial for us to improve diagnostic safety, because one, you are expecting a patient to communicate better. How will the patient communicate better if the diagnostician or the healthcare workforce are not there to provide the patient with avenues or channels or better ways of communicating and reaching the diagnostic team? So within the team, we will always have those task factors that affect the diagnostic process. One, in terms of, let's say, an atypical presentation of a disease. It's a task that you've never undertaken before as a diagnostician. It will affect how you present it. Technology and tools. For example, in the modern healthcare space, we are talking about EHRS systems. Is your system enabled to support you with the tools? For example, if in your system a result has come in, is it regarded as a critical result? Does the system has a way of alerting you that, oh, there's a critical result here that you need to review? So those are system issues that support or hamper diagnosis safety within the healthcare ecosystem. We've got organizational issues in terms of healthcare professional capacity, care coordination and innovation, and also availability of test platforms within the organization. So out of the work system, we've got outcomes, and the outcomes can either be to accurate and timely diagnosis or a diagnostic error or a near miss. So whether the outcomes also will always affect the patient in terms of the patient at the patient level, the outcomes. For an accurate and timely diagnosis, you realize that now an outcome there, you will be having better managed patients with, let's say, for example, if it's an inpatient, you'll have a patient spending more days within the hospital and the rest. And then we also have learning system level outcomes, and then the learning system. Within the learning system, the expectation is that whichever information is coming out of the diagnostics process should be pulled into the system to provide avenues for improvement in future. So the next, in terms of clinicians, how can we support our patients to communicate better? And when you look at improving the diagnostic process, there are a number of issues that we need to look at. For example, we'll be talking about policies and regulations. Are they speaking to what you need to do? Diagnostic platforms, are they available? Are they accessible? And have they integrated how we are able to access them? And then we talk about health IT, the information, the tools that we use, as I've described previously, and the referral systems. In most cases, when a patient is referred, let's say, to the next level of care, the referring diagnostician or physician or clinician, one, has no way of getting feedback of how the patient fared back or what happened, or even the receiving clinician or consultant has no way of feeding back into the system that, okay, the diagnosis that you made that the patient came in was wrong, and this is what should have happened. So those are avenues of building up the system and ensuring that we learn from error. So in terms of patient engagement, these are the key things that I think we as clinicians or diagnosticians need to support our healthcare with. One, let's use our patients as safety nets. Proper patient education ensures that the patient is kept aware of what they are required of. And then we need to provide FAQs. For example, within the disease-specific programs, you can generate a list of to guide the patient that when you're in this process, these are some of the questions that you need to be asking your clinician, so that the patient does not go home and say that, oh, I wish I had asked the doctor this. So those are some of the FAQs. Those are the way we can support our patients. One, two, engaging the patient directly through education, and also engaging the patient indirectly. This means that we engage the patients through support groups or advocacy groups that are speaking the patient voice. One, by involving them in the management process, for example, for healthcare organizations that have patient safety groups or committees or quality improvement teams, having a representation from the patient voice is so important, so that as we pick challenges and improvement ideas, the patient voice is also added into the system. We use patients as an alert system. For example, when you send your patient home and tell them you're supposed to come back in a week's time, but if you see 1, 2, 3, come back immediately. Those are alert systems and reminders. And even, for example, this test result should come up in the next 1 week. So after 1 week, the patient is mandated to remind you, Daktari, have you received my test result? So those are elements that we can support our patients, and also enable our patients to access their own medical records. For example, a patient moves from facility A to facility B, and that history should move with the patient. As a country, we are not yet there where all the EHRS are integrated, even though there's some progress on that will make that easy. But the patients should be supported to access their own medical records. There are some facilities that even the test results the patients are not given to go to carry, and even to made aware of what has come out of it. So when the patient transits into the next healthcare ecosystem, it's sort of starting from a blank or from a zero. So those are just a few ideas on how clinicians can stop patients, can support patients, but patients also have a role. For example, as diagnosticians or clinicians, we expect our patients to be good storytellers, basically. Provide your history in a concise and clear manner, in a chronological order. And then the patient also should be open-minded. This is what we expect from the patient. And I think maybe COFPAC can help us here. When the patient steps into the ecosystem, remember, as a patient, you had experienced this and you've done your background check. You may have your own perceived diagnosis, but when you come into the healthcare ecosystem, seek the opinion and be open-minded. The patient should always have a questioning attitude. For example, asking what else could this be? It enables the diagnostician to develop a differential, or even, is this test necessary? It enables the diagnostician to have that thinking. Do I really need to order for this test in terms of wastage or misuse and overuse, for example? And then the patient education entities, we need, as much as possible, I know healthcare organizations have different ways of reaching out to their patients, but we need to make them in a way that the patients are able to interact and engage with them. The way patients keep their records, keeping track of their hospital records and the rest. And also the patients should know when to escalate and when to come back and when to move for a second opinion. So that is what's supposed to give us a move to diagnostic error. And with that, I give us a case scenario. A 47-year-old male tracker, newly diagnosed HIV, complaints of headache and joint pains. Physical examination is intact. Lab work, blood slide positive for malaria, 100 cells per millimeters. Serum CRAG is positive. First-line antimalarial analgesia given. TCA 1 week for ART initiation. Readmission 72 hours later via the AE, present with severe headache and erratic fevers. Physical examination, key dehydrated. Assessments, LP for CSF, CRAG positive. diagnosis, cryptococcal meningitis in AHD, treatment, appropriate management for the diagnosis as per protocol, status of the patient, comatose, and day 5 in the ICU. So let's chat in our responses.
Yeah, so we may post our take. Mgonjwa wetu alikimbia sana na ugonjwa within a span of 1 week in the ICU, and this actually to me is a typical scenario, and these are some of the cases that we interact with, and you brought it very well within the HIV perspective. So what's your take, team? Would probably chat. We'll sample a few of them.
Yes, let's chat and sample.
So Pamela is saying initial history was not adequate. I agree with you. That's true. I know. I know. Yeah, after 1 week. I know some of them are still reading and digesting because the cases are becoming more complicated. 47, truck driver, probably is in Nigeria. Missed differential diagnosis in line with new HIV diagnosis. That is from Beatrice Bwabi. Hazel Oyungo is saying an assumption in the history taking, physical examination, lacks important positives and negatives. The overall, those are missed diagnoses. Vincent Oyato, this is a patient for immediate admission, so there was poor management that was noted. Mary Kirimi is saying there could have been an element of iris with this patient. Nicholas Rono, physical examination findings were very scanty. Very true, I agree with you. Things to do with iris, very true. Missed diagnosis, very true. Emma Momanyi is saying this was a case for immediate admission. Okumu Michael, I'll share the slides. Okay, we shall. There's no problem with that. Yes, so there's quite a number of reactions in the chat box. Back to you, our presenter.
Yes, I agree. So you realize that one, all the issues we'll be talking about, whether in terms of clinical reasoning, information gathering, if you've if the scale is not sufficient enough, we'll miss something. And then two, if our systems, we have no appropriate alert systems or debiasing systems, we also realize that we will be missing on something. For example, if you look at I have heard someone say this was a case for admission. So within the system, what is it that alerts the diagnostician that when you get this, send for admission? When you get this, rework better. And as I was looking at this case, you realize that, okay, within the HIV care and treatment guidelines, there's that element of CD4, let's say less than 200 or serum CRAG positive. What do we do? So that should basically move you into the next course of action. So these ones, we call them clinical support, decision support tools. Within the facility or within the healthcare organizations, we have clinical decision support tools. So all along, we agree there was an error here, diagnostic error, and the diagnostic error was missed. And then in terms of bias, you'll be looking at anchoring bias or availability bias. So in anchoring bias, you look at the first impression that comes through to you and comes through to you once the diagnostician had seen a positive blood slide for malaria parasite, went through with that and did not look at the others or in terms of confirmation bias. So whatever affirms what you are, let's say, maybe you are well conversant with, and you will basically provide treatment on that and move. So that is how we miss diagnoses. And now for this case, you realize now this patient was to come 1 week later, but within 72 hours, this patient ended up back comatose and has been now 5 days within the ICU. So that is basically the burden of diagnostic errors. So for healthcare organizations, this is how we can support the work system to improve diagnostic safety. One, within an organization, ensure that you have appropriate diagnostic error measurements, and you provide your work system with clinical decision support tools. The decision support tools here, the most commonly that we use are the algorithms that we have around. So the algorithm, you don't need to have it like within the main pamphlet. It's supposed to be something, let's say bedside, or it's supposed to be within the clinician's room. And some clinical decision support tools are, some of them are embedded within the software as the EHRS that we use. It makes work more easier. And the decision support tools can also come in as part of the multidisciplinary team reviews. When you are looking at a diagnosis, it enables the team to step back and review a diagnosis and think, are we getting it right? Is this the way to go? And then in terms of diagnostic platforms, as an healthcare organizations, it is the responsibility of the work system to ensure that the platforms are available, accessible, and optimized in terms of use and integrated so that the information is able to flow back into the system. Expert support within the healthcare organization. Do I know as a clinician sitting at maybe at the clinic, do I know who to call on to next when I need a second opinion, for example? And also navigating the health system workspace within the facility, within the healthcare system. For the patients, most patients need support to navigate within the healthcare ecosystem. For example, you may send a patient to the lab. They don't know where the lab is. They find it too tiring. They go home. So those are kind of the support that we talk about. And then in terms of the safety culture, these are, as the healthcare organization, you need to empower your diagnostic team so that everyone within the diagnostic team is able to speak up and say something safely. For example, the nurse in the inpatient unit that interacts and touches the patients on a daily basis should be psychologically safe to say that, okay, we've been giving this antibiotic or this prescription for 3 or 4 days now, but this patient is not making progress. And the entire team should take that up. And in terms of speaking up, this also comes to the patients. Are we giving our patients room to speak up and ask questions and delve more into the care that they're receiving? Mindfulness for every organization, we're talking about mindfulness here. Can we talk of collective mindfulness and individual mindfulness? For the individual, being self-aware that, okay, this case I'm handling, I've never handled this before, I need support. That is being aware that, okay, this is potentially a zone that I may make an error. For collective mindfulness, for mindfulness of an organization, each and every healthcare ecosystem will experience an error. Whether you are a super specialty hospital, you'll have errors. Whether you are a teaching university hospital, medical errors will be there. So when healthcare organizations lose focus or lose sight of the inherent nature of error in the healthcare space, the errors occur and they are swept under the carpet. That is what happens. Case reviews for organizations, basically the routine case reviews, the normal ward reviews, and also expert reviews. In terms of patient engagement, I spoke about this. As an organization, you should develop avenues or channels of engaging patients into the care processes within your healthcare space. Whether, for example, in most healthcare spaces, we talk of community dialogue days for the entire workspace, for the entire health facility. Yes, apart from the community dialogue days, how do we dialogue with the individuals, disease-specific support groups or patient groups or advocacy groups to get more information and also incorporate them and engage with them to co-create safety within the workspace. Communication as a bit, we need to ensure that we close the diagnostic loop within the healthcare ecosystem and also integrate care coordination within the facilities. And then in terms of professional communication, as diagnosticians, I know we rarely call back the radiologist that this radiograph or this result we sent is not really aligned with what I was seeing with the patient, or even I was expecting this and this is this, and even ask what else can this be. So in terms of that communication between the diagnostic platforms and the diagnosticians, and also within the intra-professionals in terms of prior reviews, we should make this a habit for us to gain diagnostic excellence. So I think finally, I think this is just a tool to support organizations. It's we call it the safety diagnostic measurement, safer diagnostic measurement framework. It just provides an organization with the various diagnostic process dimensions that you can measure and get feedback on. And whatever you measure should be basically provide with reliability and validity of what is going in. And the measurement approaches should be both retrospective and prospective. Retrospective here, for example, the maternal death audits that we have, the death audits, those are usually retrospective, and the autopsies, those are retrospective. But prospective in nature, as the patient walks through the ecosystem, we need to, for example, make use of case reviews. We need to make use of, let's say, there are some EHRS systems that have diagnostic tools that are embedded in there that are able to measure your accuracy in terms of diagnosis. For example, there's one called Calibrate Diagnosis. A Calibrate Diagnosis is a software tool. It's embedded within some EHRS systems. As a clinician or a diagnostician, you can run through the diagnoses that you've made through the tool to see where the accuracy level and error level or error rates. Whatever you measure should basically bring the organization closer to collective mindfulness, as I have said, and enable organization to learn from what is happening. And it is through learning that the organization will develop better measurement tools. And that is what gives us safer care for them and improves healthcare value for the population, and also improve better patient outcomes. And whatever comes out of this, one, for the population, this is what now informs policy and practice in terms of preventing diagnostic errors. And for the patient outcomes, this is what now you plow back into the healthcare work system as improvement ideas or change ideas to work on, so that at the end of it, within the organization, you have that shared accountability in improving in diagnostic safety. And this is supposed to be something, it is beyond the clinicians directly. As we've seen, the diagnostic process is not now just within the clinicians. It is beyond them, and it affects, it's part and parcel of the system that they practice in. So this is just a few reference, and I will end it there, Peter. I will end it there as that, and maybe a few areas that maybe you might have wished that I touch on or that I didn't touch on, I will highlight just as we go. Thank you all.
Wow. Thank you very much, Daktari, for that wonderful presentation. Indeed, it was insightful, and I think this is the first time we're having such kind of conversation within this team. Majority in this group are basically HIV, TB gurus, and of course, the normal clinical practice. But with the World Patient Safety Day, which was marked yesterday, and with this kind of presentation, I think we are having a different, we are going to have a different opinion, a paradigm shift in how we handle our clients, and particularly for us and for the team that is within the HIV health care space. It's now an opportunity to ask ourselves, when we are in that facility, the kind of care and support that we are giving to our patients, particularly those who are coming with advanced HIV disease. And you've actually seen, like in the case scenarios that you have presented to us, they really mimic our day-to-day activities and the cases that we interact with. So team, I want to make this an open, maybe to take a few 3 or 2 questions. In the chat box, I've seen a few questions that I would like to read out, maybe for your attention. And one of the first question was from Vincent Oyato. He's asking, what is the relationship between patient safety and patient rights and obligations? Maybe we could handle one at a time. That is from Vincent Oyato. We'll only take 3 questions.
Yes, patient safety and patient rights and obligations. If you look at you run through the the presentation that I've made, I've also spoken to the patient in terms of the obligation, and the challenge that we've had for a while in the healthcare ecosystem is that healthcare has been so paternalistic, whereby let's say the doctor knows it all, and the patient is there to oblige and to follow through. And that shift there, that thinking is slowly changing, where we are talking about co-producing safety, co-producing quality of care with the patients, because we've realized that the patient sits at the center of all of this, of the entire work system. So when you speak about patient rights, and I think in the initial slides where I was talking about the patients for patient safety, out of that declaration, out of that the London Declaration, that is where we started having service charters, because the patients felt that we need to know what is happening. And the need to know what is happening also comes with the obligation of the patient. And in most cases, the patients need to be supported to engage constructively in their obligation. When you talk about the patient rights, yes, there is a right for care for everyone, and the obligation that comes in to support co-producing the quality of care that you want, to ensure that care is safe for you. So they are basically, let me call them two sides of the same coin. They work part and parcel with each other. For example, now following the activities of the World Patient Safety Day, we are talking about improving safety. And more, we need to see information materials or activities or education information or advocacy groups talking to patients that when you go to seek care, this is what your care provider expects of you. For example, we expect of you to be a good storyteller, for example. And if you're not able to tell the story, bring someone along who is able to tell the story. So that is in terms of patient rights, patient safety, and patient obligation. So they are basically two sides of the same coin. They have to move part and parcel with each other. I hope I've responded to Vincent's.
Oh, great. Great. Maybe we could take two more. Hazel Oyungu is asking, does patient FGD, focus group discussion, play a role in improving quality of care or services?
Yes, indeed. You know, the patient's focus group discussions, for example, in let me speak for the space of healthcare, HIV care. We've got patient support groups, and the idea of the support groups, one, is to provide an avenue for the patients to feed back into the system on what's not happening right. And for example, it is through patient support groups that facilities have developed better triage systems. I think we agree on that. And it is through support groups or patient focus group discussions that facilities have relooked into their turnaround times for the services that they provide to the patients. And it is through these focus group discussions that facilities have developed mechanisms to ensure that care is available, whether it is a weekend or whether it is on a holiday or whether it is raining or throughout the season. So focus group discussions is one avenue of engaging the patients into co-producing the safety or the quality of care that we seek.
Thank you. Maybe last question. Pamela Anyango is asking, for system errors where the patients can't get the drugs as prescribed, and so due to financial or social background, the patients misses treatment. What can be done? Oh, this is a systemic question, a system question or something. Yeah, for system errors. Yes.
For system errors, you see, let me use one of the pioneers in patient safety. They say that the problem with patient safety is not careless people. The problem with patient safety is bad systems. So when I talk about collective mindfulness of an organization or a healthcare ecosystem, it brings the organization to a realization that their systems are imperfect. It brings the organization to the realization that they still have more to learn. It brings the organization to the realization that the care they provide will inherently be in error. So once an organization realizes that, it becomes quite easy to engage. And with the kind of work that is going around in terms of the patient safety and quality improvement space, the work at the policy level or the organization leadership level, one, is to change the leadership mindset and also the organizational mindset in terms of development, better cultures, better organizational cultures that can support safety, because it's a systemic issue. It has to be solved within the system, within the confines of the system. You remember when the slide on etiology of errors, we're talking about system factors. So you and me, as the diagnostician sitting with the patient, we are just inheritors. We've just inherited the deficiencies or a defective system. That's what we've inherited. And when you inherit a defective system, it becomes quite difficult to make it work. But over and above, you agree with me that out of 100 patients, we'll get it right 99%. And when you get it right 99%, it does not mean that the system is perfect. Just the way, because we make our own arrangements, workarounds to get it right. So systemic errors are addressed within the systemic lens. And the first avenue addressing that is changing the mindset towards collective mindfulness. If the organization is not mindful collectively, it will not make, you as an individual will not make progress. Thank you.
Thank you, Edward. I think in the interest of time, I will just read maybe a few comments. They're just compliments, great presentation. Somebody saying they foresee a scenario where healthcare providers make clinical judgment or refer patients outside for laboratory workups, but sometimes the facilities are insufficient in terms of commodities. I think you have addressed that about the system. Lynette Gishana, indeed, that is a great knowledge. Lois Kihungi is saying, thanks for the informative presentation. And these are the kind of conversations that we need to have as healthcare professionals. And she's saying that it seems we are going to have a lot of apologies to our patients because we have been making a lot of errors. But the fear is the bad name. And if we are really going to admit the errors, we are also forgetting we are potential patients. Thanks, Lois, for bringing into that context that we are also potential patients. And it is high time that as medical practitioners, we start thinking of how we're going to have a conversation with our patients. If it means apologize, we own up in a professional way. Roger Skiparos, what the big causes of defaulting in level facilities? Is it a safety or compliance? I think we'll share most of this information in the interest of time. Pamela, in general comment, in the case of apology to patients, especially when mortality is involved, the relatives can take very drastic steps that may not be friendly. And as we wrap it up, I also want to take cognizance of the fact that as a country, we have emerging issues, and some of them, of course, we know includes a litigious community. Our patients are getting or becoming litigious in terms of able to take legal actions against medical practitioners. And this is something that we also need to be alive to as healthcare providers, that in the process of making that diagnostic error, we may land in court. I want to also to bring us to speed of the Constitution of Kenya 2010, Article 43, subsection 1A, that says that every person has a right to the highest attainable standard of health, which includes the right to healthcare services, including reproductive healthcare. So as practitioners, these are some of the things that we need to look into. Over and above, we have practitioners' code of ethics, which we also need to align ourselves to very clearly. And another thing is about the healthcare workers' indemnity cover. I think this is one of the things that if we had time, we could have this conversation for the whole day about improving patient safety, improving diagnosis, and just being aware that we are in an era where our patients are likely to take us to court if we make these mistakes. So always let us also remember that we are dealing with the 6R, the 6 R's of medicine. That is the right patient. Do you have the right medicine, the right route, the right dose, and the right time? And of course, let us also not forget about the fundamental principles of medical practice or medical ethics. I'm talking about the autonomy respect the patient's rights to self-determinations, and another principle we call beneficence, the duty to do good, non-malfeasance, the duty not to do bad, and justice, among others. So as we go back to our respective facilities this morning, I want us to have these conversations amongst ourselves. Are our patients safe in our hands? When these patients are missing appointments, is there something that we can engage them into so that we don't have missed appointments? When these patients come to the facility for the first time, the second time, the third time, and we are making a diagnosis of TB and HIV at a time when these patients are already in stage 3 or 4, are we doing justice? Are our patients safe in our hands? When you are making that diagnosis of cryptococcal meningitis, and with all the gaps that we have seen, whether they are systemic, whether they are healthcare provider, can we make it better? Another question we need to ask ourselves, are we engaging our patients in a meaningful engagement, what we call MIPA, meaningful involvement of patients living with HIV? The case management approach, we cannot underestimate the importance of the case management approach insofar as HIV and advanced HIV disease is concerned. And we are in an era where we are referring to our patients as customers, the recipients of care, and lastly, effective communication. So I think with that, we want to come to the end of this presentation for today. The whole of this month, we say we are still going to have conversations about patient safety, and that is what is going to be our core in terms of diagnosis. We were planning, if time could have allowed, to have a discussion on antimicrobial resistance, and just to see how we can also improve diagnosis, how we can improve on our prescriptions, because we know the antimicrobials that we have are not even now responding to the best antibiotics that we have in the country, because level of resistance has gone up. So if you get an opportunity over in different platforms, we'll share with you, because this is the conversation that we are having in the course of this month. To this end, unless there is any burning issue, and maybe your last words, Mr. Duoro Chen, maybe the last comments that you may be having before we wrap it up.
Thank you, and I appreciate COFPAC and Nairobi, TWG, on putting this up and having me today. I think what I would say is that every year, when 17th of September starts, a new theme comes, and this theme is supposed to push us through to the next 1 year. So within the 1 year, we're supposed to be talking and putting in mechanisms to improve diagnosis so that we prevent diagnostic errors. So the other thing that I would also say is that, yes, you realize the content is so wide, we could not handle everything at a go, but we'll be looking at to ensure that we keep on engaging to bring out this information closer to everyone, because patient safety and diagnostic issues and just quality of care improvement is just so wide. But let's take this as a start, and let's keep engaging. And I like what Peter said. You know, when you think of a patient, you're thinking of someone else coming to visit you in the clinic, not knowing that you're also a patient in waiting. And we realize that everyone will always be a patient. And within the work that was done, within the last quote you see, it is likely that most of us will experience at least one diagnostic error in our lifetimes, sometimes with devastating consequences. So I leave it at that. Let that keep us thinking, and as we move into the next phase. Thank you so much for everyone for dialing in and listening and engaging. Thank you.
Thank you, Dr. We appreciate you. We appreciate your time. We appreciate the county through the Department of IPC and Patient Safety. We really appreciate the team that took their precious time to attend this. Yes, Vincent Ochieng will organize more of this. Ezra Talam, yes, we have a mismatch of just job descriptions. I think that is something we can relook at. Pamela, it is true. We need to reassess this. Alice Wamboi, I agree with you. We need more discussions with everyone in the facilities, especially nurses and clinicians. Yes, of course, that is where we have a major issue, because that's the people who are interacting with patients and making very critical decisions. Yeah, so the rest we'll share with you. I don't know whether Carol is still on board to close the meeting for us. And then we have a word of prayer from a volunteer to close it up for us. Otherwise, on behalf of Nairobi Regional TWG, the county government of Nairobi, and also COFPAC organization. I want to thank you all for taking time to participate in this wonderful discussion. And I hope to see you next time when we continue with these conversations. We are planning to have a different conversation concerning antimicrobial resistance. If we have an opportunity, we'll of course share with you and have that discussion. Otherwise, over to you, Caroline. Sorry, close it for us if you're still on this call.
Okay. Thank you very much. I'm right here. And everyone who has participated in this very great discussion, I say thank you on behalf of Nairobi County Government, the health sector. Allow me to declare this meeting closed until next time. Bye, everyone. Thank you to the presenter and everyone who participated.
Thank you. Thank you. And
Thank you, everyone.
it's there.
Thank you.
Asante
We
sana.
are to have a word of prayer. I had.
Oh, yes, yes, yes. We are praying for us then. Okay.
Everlasting God, the Father of our Lord Jesus Christ, thank you this day to be able to we can walk towards patient safety as we do this year with a team of diagnostic errors, Lord. Leaders that will run with this team because we them. Amen.